Okay, my second half of my presentation is on maintenance therapy. This is actually the most controversial area in the area of myeloma management. So why should we consider maintenance therapy? And these are the main reasons. Can we prevent disease progression? Can we deepen the response because we're giving additional agents? And can we actually improve the overall survival by giving the maintenance therapy? Not just control the disease, but do the patients live longer? So when you look at maintenance therapy after induction therapy, this is without transplant, there are a few papers that have been published. This is on interferon. So this is, again, we talked briefly about the multiple myeloma trialist group. They published over 4,000 patients. It was a meta-analysis of over 4,000 patients published in 2001. And there was a approximately 5-month benefit in progression-free survival. But for those of you who have used interferon for the treatment of patients, 5 months and all the toxicities associated with interferon, most people decided this was probably not in the patient's best interests. There was another trial, which I'm going to show you more data, that was actually comparing interferon directly with observation, and there was no benefit in overall survival. This was a large American intergroup trial. Patients got VAD. VAD is in vincristine, adriamycin, dexamethasone, and then they had either an autologous transplant, a small group had an auto transplant, or the patients had consolidation with VBMCP. If you responded, you got randomized to interferon or no interferon. And bottom line was there was no difference in the progression-free survival with or without interferon. It did not improve outcomes. And there was no difference, even though it looks like there was a significant difference in overall survival. There was no significant difference in either progression-free survival or overall survival in patients who had interferon. And after this study came out, essentially no one in the United States was using interferon anymore. What about corticosteroids and maintenance? There are really just 2 trials. This is a trial in patients who were treated with, again, with VAD, vincristine, adriamycin, dexamethasone. Then they get randomized to either prednisone, 50 milligrams every other day, or 10 milligrams of prednisone every other day. There was an improvement in progression-free survival, 14 months versus 5 months. And in this trial, relatively small numbers of patients, there was actually improvement in overall survival. This never really caught on in America, even though they did show this difference in this group of patients. There was a Canadian trial where they used dexamethasone 40 milligrams for the first days of each month compared to observation after a melphalan-based induction regimen. They did see an improvement in progression-free survival, 2.8 months versus 2 months, no difference in overall survival. This is all the maintenance therapy that existed up until recently. So this is an Italian trial. It has a fairly unusual design in that they compared a 4-drug regimen to a 3-drug regimen, and the 4-drug regimen got maintenance therapy with bortezomib thalidomide. So bortezomib, melphalan, prednisone, thalidomide, with bortezomib thalidomide as maintenance therapy versus bortezomib, melphalan, prednisone, similar to the VISTA trial. What they found was complete remissions did go up in the 4-agent group versus 3. And with the maintenance therapy with the bortezomib thalidomide, progression-free survival was improved in the patients who had the maintenance therapy, but there was no difference at 3 years in overall survival. And my guess is that with further follow-up, this has been published, there will probably still fail to show an improvement in overall survival because this group of patients will probably be salvaged with thalidomide or lenalidomide-based therapy. Now, what was interesting, which we've already talked about a little bit before, but this is the main source of information about the twice-a-week bortezomib versus once-a-week bortezomib. This was actually not in the initial design of the trial, but after the first 60 patients were enrolled on this trial and they had a lot of problems with neurotoxicity, the trial design was changed from a twice-a-week to a once-a-week administration of the bortezomib. Now, twice-a-week bortezomib is probably still more potent if you can get the drug administered in that group of patients, but what you see here is the actual dose delivered was 41 milligrams per meter squared twice a week. It was almost identical on the once a week because so many of these patients had dose reductions or came off of the drug because of toxicities. So the total delivered dose is exactly the same. This is not necessarily a potency trial because the dose was essentially half of what they expected to deliver. When you look at the remission rate, 25% complete remission, 23%. When you look at the 2-year progression-free survival, it's exactly the same. And when you look at the neuropathy of any grade, 43% versus 21%, and the severe neuropathy, 14% versus 2%. Based on this information, a lot of us have changed to once-a-week dosing, even though we may be losing some of the potency by reducing the dosing. Now, with the onset of subcutaneous bortezomib, maybe we should think about doing the trial again, 2 versus 1, and see what the outcome is. Let's skip this one. So this is the trial that was just published by Dr. Mateos from Spain. This is the MPV, bortezomib, melphalan, prednisone, and switching out melphalan for thalidomide. So this is the first aspect of the trial, was a bortezomib-based regimen with either melphalan or thalidomide, and then there was a second randomization to bortezomib prednisone versus bortezomib and thalidomide. When you look at the induction regimen, response rates for melphalan versus thalidomide, exactly the same. The depth of the response, the complete and near complete remission is exactly the same. When you look at the progression-free survival without the maintenance phase, even though it looks like there should be a difference 34 months versus 23 months, it was not statistically significant, and the same thing was true for the overall survival. So there was really minimal improvement of thalidomide versus melphalan, which is somewhat surprising. When you look at the patients who went on to have the maintenance therapy, this is bortezomib thalidomide, bortezomib prednisone, response rates were impressively improved to essentially 100%. When you look at the depth of response, it goes from 20% to 44% with bortezomib thalidomide, 40% with bortezomib prednisone. These are not statistically different. So when they looked at the long-term, again, that's not long-term, this is 2 years overall survival, there's no difference, but there does appear to be a trend in progression-free survival in patients who are treated with the thalidomide plus bortezomib versus the prednisone for bortezomib, no matter what your induction therapy. So this is VMP, followed by bortezomib thalidomide, this is not reached yet, versus 32 months. This is the bortezomib thalidomide prednisone with the bortezomib thalidomide, again not reached, versus 27 months. So there appears to be that there may be a trend to improvement in the bortezomib thalidomide versus bortezomib prednisone for maintenance therapy. Published in Lancet Oncology just recently. This is a trial that was presented by Antonio Palumbo. This is the European registration trial for lenalidomide for frontline. It was the intent of this trial. It was a 2-part trial. The first part was comparing MPR versus MP. And to make a long story short there, the MPR is superior to MP. The second part of the trial was to compare MPR with lenalidomide maintenance versus MPR that stopped at 9 months of treatment. And that's what's shown here. So we have MPR plus R, where the lenalidomide was continued, versus MPR that was discontinued after 9 cycles of therapy. And this is the data that's shown, that has been presented by Antonio. This is the MPR plus R, showing a superior progression-free survival. This is the MP. And actually the MPR also is superimposable on here. So if you this is the MP and the MPR curves look exactly the same. The MPR plus the R, the patients who had lenalidomide maintenance, had a superior progression-free survival. There is no difference in overall survival at this point in time in this trial, although the follow-up is still fairly short. And that's what's shown here. This is the overall survival. The curves are superimposable at a median follow-up of 21 months. So that's non-transplant maintenance therapy. That's all that exists at this point in time. This is the first large-scale transplant trial, randomized trial. This is the French trial, VAD, 2 transplants. Patients got randomized to thalidomide and pamidronate alone, and no treatment for observation. And what you see is the 3-year event-free survival was statistically superior in the patients who had the thalidomide. And the 4-year overall survival projections was also statistically superior in the patients who had the thalidomide versus those who didn't. Unfortunately, the thalidomide was tolerated very poorly, and as it turns out, in this group of patients who had the superior survival, it was really the patients who had a low beta-2 microglobulin and those who did not have, that had less than a very good partial remission. So if you had a good partial remission or you had an elevated beta-2 microglobulin, it did not improve your outcome. And there's been at least 4 other trials also looking at thalidomide as maintenance therapy. Most of the trials show an improvement in progression-free survival, and almost none of the trials show an improvement in overall survival. And that's what's summarized here. These are some of the trials that are available. This is an Australian trial. I need to take this trial out. I don't want to even discuss that. But there's actually a Canadian trial that shows similar activity. This is an Arkansas trial, the French trial. There's a Canadian trial and an Australian trial. And they essentially all show an improvement in progression-free survival, and few of them show an improvement in overall survival with thalidomide. So thalidomide's not tolerated very well. Most of the dropouts and the difficulty is because of neurotoxicity. So now there have been trials conducted with lenalidomide instead of thalidomide. This is the American trial. It was not been published yet. It's been presented most recently at the American Society of Hematology meetings in December. Patients had to have myeloma. They went through 1 autologous transplant, and if they did not have progression, they got randomized to either placebo or lenalidomide. The patients who had the lenalidomide had a median time to progression of 42 months versus 21 months, almost a 2-year improvement in progression-free survival. When you looked at the overall survival, there was no difference. And there will never be a difference in this trial because the monitoring board saw this difference in progression-free survival, and any patient who had not progressed was automatically crossed over to the lenalidomide. So we will not see a difference in this. Yes?
Actually, just to give you a heads up, not true. In the IMW meeting, you'll see that there is actually the absolute...
In this data?
Yeah, there is. There's a survival difference emerging. Just to share with you, because that'll be updated in the meeting next month, but I think it's fair to share with you. I completely agree. Everyone assumed that that would be the case, but pointing to the strength of lenalidomide maintenance, even with crossover permitted, we will show at the IMW meeting a survival difference in favor of lenalidomide.
Thank you, Paul. Did not know that.
Yeah,
I can always learn.
But no, not at all.
Because the French also show survival.
But the interesting thing is that you'll see they have consolidation in both arms. So in fact, with that consolidation step, the survival difference is taking longer for the French to show than we are in CalGB. So, sorry, I'm one of the CalGB investigators, but I don't wish to break the sort of embargo on the IMW, but I think it's probably fair to share that with people because it's very relevant to what's coming, isn't it? Yeah.
So as it turns out, so one of the questions that's been raised, what if you had previous lenalidomide? Did that impact whether you would still benefit from being on lenalidomide maintenance? So did previous exposure change the outcome? And the curves are very hard to interpret, but the answer is no. Even if you had previous lenalidomide, you still had a benefit from lenalidomide maintenance. So they concluded that lenalidomide had a superior progression-free survival, and now Paul's saying that there is a trend, if not a statistical improvement in overall survival. This was true regardless of what your beta-2 microglobulin, whether you had previous thalidomide or lenalidomide before. So AEs, adverse events, were present, but these, about 13% of the patients dropped out because of adverse events, mostly tolerated quite well. So this is a French trial, same basic concept, but it's much more complicated. And to go into what the next slide set's going to be, you have to appreciate that this is a much more complicated trial. So this is the 2005-02 trial. Patients went through there was 4 different combinations for induction therapy. Half the patients in this trial had previous anthracycline, and half the patients in this trial had previous etoposide. This is important so you understand what the next series of slides is going to be. But it started off with induction therapy, then they had 1 or 2 transplants, depending on their response. They got consolidated with lenalidomide alone for daily for 2 months. Then they got randomized to either placebo or lenalidomide. What they found was that the response during consolidation, when you gave the 25 milligrams for 2 months, you improved the complete remission rate from 13% to 19%, statistically significant, and the very good partial remission, 58 to 68%. So lenalidomide as a single agent for 2 months did deepen the responses. It's a little bit hard to interpret because they still could be responding from their transplant, but that's a different issue. When you look at the progression-free survival, lenalidomide group had a superior outcome, highly statistically significant compared to the placebo for progression-free survival. And when you look at the best responses, because of consolidation, which Paul was alluding to, there was really not much difference between the overall best responses in the group, but there was definitely a difference in the progression-free survival. So there are 3 trials I've just presented. This is the Italian trial of MPR plus R. This is the IFM, the French trial. This is the American trial. They all show significant improvement in the progression-free survival in all groups. This group does not show an overall survival benefit. This one, I think there's a trend, although as Paul alluded to, this is a little bit difficult to interpret. And now Paul's just informed me that the most recent data analysis of this trial also shows a trend to improvement in overall survival with lenalidomide maintenance. The problem is this very complicated slide, and I apologize to you for this, but this slide is very important for people that really want to know the exact data. So what this slide is about is second malignancies in people who've been on melphalan-based regimens followed by lenalidomide. So this is the Italian MPR plus R versus MP. This is the French trial, and this is the the American trial. What you see here is second malignancies in the MPR plus R is 8% of the enrollees. This is patients who stayed on lenalidomide. If you stopped after 9 cycles, it was 6%, but if you never got lenalidomide at all, it's 2.6%. This is the French trial, 5.6 for those who had the lenalidomide versus 1% for those who did not. And this is the US trial, 7.8% versus 2.2%. Now, some of these were solid tumors, and I'm more than happy to hear Paul's opinion on this, but it's hard for me to imagine that these patients developed solid tumors within, particularly the follow-up in the CLGB trial at the time that data was presented was only 18 months. So it's hard to imagine that we had solid tumors that developed in 18 months that didn't pre-exist. So, but we do see, so if you subtract, even if you subtract the solid tumors, we're still seeing hematologic malignancies that are higher in the groups that had lenalidomide versus those who did not have lenalidomide after a melphalan-based regimen. Now, I will tell you, because I've seen the data from Celgene, that this is not true in the relapse setting. If you give lenalidomide dexamethasone in the relapse setting, there's no increase in second malignancies. If you give lenalidomide and dexamethasone in the upfront setting, based on the ECOG data and also Paul's experience with RVD, there's no increase in second malignancies. There's some interaction between melphalan followed by lenalidomide that predisposes a small but a significant proportion of patients to get second malignancies. And they're across the board. AML, there's also an increase in B-cell malignancies of B-cell ALL and non-Hodgkin's lymphoma is also increased. And we do not have an explanation for why this develops. This data is still maturing. All these trials are still collecting more data to see if there's a pattern that's involved with the development of these malignancies, but it's going to be very difficult because if you actually look at the actual numbers, we're dealing with small numbers of patients. So 150 patients got MPR, 7 of those had hematologic malignancies. It's going to be hard to determine what differences were between these 7 patients and the other because there's so few patients that have this. But it's a very real concern that's going through the entire myeloma working group about what to do with this data.
If I may, David, just to go back to that slide, I think a very important point, just to look, is this is a beautiful slide to present, because if you look to the far right-hand corner here, I think that gives you an idea of the scope of the problem, doesn't it, David? You've got 3.4% versus 2% in that bottom right-hand corner. And to my thinking, that I completely agree with you that it's an important issue, but it's tremendously important to us in the myeloma community also to not see this out of perspective. Because one factor that, without a doubt, in the CLGB experience, we are auditing very aggressively for is what we call ascertainment bias. Because in reality, those patients who are on lenalidomide are followed more carefully. Those who are on placebo and go off for any reason, or allowing that people cross over, of course, but the reality is for that subset of patients who've gone on for any reason, they're not followed as carefully. So I think when you look at that bottom right-hand corner, I think there's definitely something, and I completely agree with David that there's a genotoxic interaction with melphalan and other chemotherapies that may be very real, given our experience with lenalidomide in other settings. But I think it's tremendously important not to get this out of perspective.
Correct. Which is one of the reasons I mentioned, if you recall,
yeah.
In the French trial, again, half the patients are getting anthracyclines and topoisomerase inhibitors.
Right.
And we don't know what impact that has on this outcome. You know, for all we know, because we don't have that data yet, it may have been that most of the patients who had, there may be something related with those class of drugs and lenalidomide. We do not know that yet. They're still collecting data. But this is the hottest topic internationally right now, is maintenance therapy and the secondary malignancies, small, but definitely there. So we already showed you the Dana-Farber French trial that's an early versus a late transplant. This is the national trial in America for patients who had previous treatment. The Dana-Farber French trial is for untreated patients. This is for patients who can have up to 10 months of treatment who are going to go to transplant. And this is again to readdress this issue of 2 versus 1 transplants, because if you look at the French trial as well as the Italian trial that show this improvement in progression-free survival and overall survival, when you actually look at the number of patients that was based on, it's about 50 in each group. So it's actually a very small number of patients that we're making this determination on. This is a very large trial. This is the American Transplant Network. This is going to be a 750 patient trial, a third in each group. We're going to have 2 transplants followed by lenalidomide maintenance. One group gets 1 transplant followed by consolidation with RVD and lenalidomide maintenance. Another group just gets melphalan and lenalidomide maintenance. And I've had a lot of people say to me, why isn't there a 4th group that just gets transplant and no lenalidomide maintenance? But it made the trial too cumbersome, and we could not conduct the trial because of the large patients involved. And this is the trial. This is the one I just alluded to. This is the Paul's trial conducted with the IFM of the early versus late. Now I should point out here that this group of patients is only getting 12 months of lenalidomide because there may be a duration. Well, I showed you the secondary malignancies. There may be an impact on the duration of therapy, although they designed this before they had that information. And the US trial, it's 3 years of maintenance therapy with lenalidomide. That may change based on government and working group input into the duration of the maintenance therapy. Now, there are some data available with bortezomib after transplant. I showed you bortezomib, thalidomide after conventional therapy. I showed you 2 trials on that. There is some data, not a lot of data, on bortezomib after transplant. This is a trial that was presented in abstract form, has not been published yet by the Nordic group, where they gave actually 6 cycles of bortezomib-based therapy after transplant versus nothing. So 6 cycles of consolidation of bortezomib single agent versus no consolidation. They found an improvement in response rates in the group that had bortezomib 20% versus 50%. There's also an improvement in the control because some of these patients were still improving at the time they were enrolled on the study. And the progression risk was lower, although not statistical yet, in the group who had the bortezomib. We don't have any more updates. I don't have any more updates on that data from a little over a year ago. This is a bortezomib thalidomide dexamethasone phase 2 clinical trial that was done by, that was reported at the last ASH meeting, excuse me. They got induction therapy with bortezomib dexamethasone or bortezomib thalidomide dexamethasone. Then they had a transplant, and then they went on what they called, what do they call this? Not little VTD. I'm trying to think what they call this. It's dose reduction of bortezomib because it's only 1 milligram per meter squared instead of 1.3 milligrams per meter squared. So then they went on VTD to see what would happen. What they see is that prior consolidation, so they had a transplant, they improved the complete remission rate from 23% to 36%. So they did have deeper responses by giving consolidation. This has a fairly short follow-up. There was a very elegant paper that's very, very difficult to understand presented by Peter Sonnenfeld from the Nordic group. I only want to talk about it very briefly. This is VAD with vincristin, adriamycin, dexamethasone. This is PAD, is bortezomib, adriamycin, dexamethasone. They got consolidation, mobilized with CAD. And then they got 1 or 2 transplants, depends if they were in the German group or not. And then they either got thalidomide maintenance or they got bortezomib maintenance. It's a very complex trial. Bottom line is they had an improvement in progression-free survival for those patients on the bortezomib group, but the thalidomide group also had an improvement compared to their historical controls. We already talked about the total therapy program. Again, this is total therapy 1 without thalidomide, total therapy 2 with thalidomide, total therapy 3 with bortezomib and thalidomide. And we already went over this, showing the improvement in event-free survival with the addition of the novel agents. So maintenance therapy, we can improve progression-free survival both with lenalidomide and with bortezomib-based therapy after conventional treatment. This is based on the Palumbo study and the Mateo study. This is MPR. This is the VT versus VP. After transplant, I showed you the French trial as well as the American trial. We do not have anything published yet, although Paul's telling me that we have both of these trials may have a trend towards improvement in overall survival, but we do not see that with any of the other trials. One of the problems with maintenance therapy is the development of resistant clones. I didn't show you this data. It's a very complex chart and I decided not to show you, but patients on total therapy 3, after they've had 4 years of maintenance therapy, when those patients relapse, their overall survival is less than 1 year. Because if you have everything and you've given them everything, what do you do when they relapse? So Arkansas shows this very impressive progression-free survival and overall survival, but once they come off therapy and they relapse, they really have a pretty dismal outcome. There's this issue of secondary primary cancers we discussed, and of course, which you can all appreciate here as well as in America, is these drugs are very expensive. Bortezomib in the US, the cycle is, you'll have to convert it to Polish currency, but it's about $4,000 a month for bortezomib a month, and it's about $8,000 a month for lenalidomide a month. So if you're on those 2 drugs, you're spending $11,000 to $12,000 a month. And we don't know for sure whether that actually improves their survival. So this is all part of this controversy about maintenance therapy, and with that I will finish. Thank you.